I really felt like with Dr. Finan and Dr. Talukder that the way they approached it, and while they are very serious and very knowledgeable about colorectal conditions, there was a lightheartedness to them that really made it feel more comfortable because it's kind of embarrassing. And I can imagine that it's embarrassing to have to make that appointment if you're even feeling any of those symptoms or experiencing anything that maybe is not right. And seeing one of them as your providers would really put me at ease because they're so approachable and knowledgeable about these conditions and these treatments.
I was thinking about like the unease and uncomfortableness of covering this topic and how they just put us at ease in a way. It's not something that you enjoy talking to your doctor about, but you recognize how important colorectal health is.
We're excited to share this conversation with Dr. Talukder and Dr. Feinen.
Welcome to The Doctor Will Hear You Now, a podcast featuring our physicians and other healthcare providers telling their stories, sharing glimpses into their daily work and mission, and showing what it means to practice medicine just a little bit differently. Healing you means hearing you, so let's talk. I'm Ben.
And I'm Lexi, and today we're discussing colorectal conditions and treatment measures. According to the American Cancer Society, colorectal cancer is the third most common cancer diagnosed in the U.S., but it's not the only condition that can affect the colon and rectum. To lead our conversation, we're bringing in two experts in this area, colon and rectal surgeons, Dr. Asif Talukder and Dr. Kelly Finan, with Our Lady of the Lake Physician Group Colorectal Surgery to talk about colorectal cancer, other colorectal conditions, and their prevention and treatment.
Well, welcome both of you, and thank you so much for joining us here today.
Thank you for having us.
Thanks for having us. It's hard to get two of us in one place at the same time.
Yes, scheduling conflicts, but we're glad we were able to connect.
Right. So I guess let's start with Dr. Finan, having you tell us a little bit about yourself. So you're currently serving as a director of the rectal cancer multidisciplinary team at Our Lady of the Lake. So can you tell us a little bit about that and your work that you do here?
Absolutely. So I've been a colorectal surgeon here at Our Lady of the Lake since 2009. We've had a strong passion in our group for treatment of colorectal cancers and have had a longstanding multidisciplinary team to focus on that and to continue to improve our program. Interestingly, nationwide, the United States did not have as good of colorectal cancer outcomes as some of our European counterparts. And the way we started studying this is they had more centers of excellence. So if you lived, in a lot of European countries, there might only be 2 hospitals you can go to in the entire country to get colorectal cancer care because they were heavily focused on it and they had much better outcomes. So out of that process grew a lot of quality initiative endeavors here in the United States. It started with something called the Ostrich Program, and ultimately culminated in a program called the National Accreditation Program for Rectal Cancer through the Commission on Cancer. So this was a very standardized program that brought together a very widespread multidisciplinary team. We have surgeons, pathologists, radiologists, medical oncologists, radiation oncologists, as well as a lot of the support staff with genetics, patient navigation, and so on. And through that system, every single patient gets presented at our conference. We review all their data. We come up with treatment plans. We present them after surgery to come up with postoperative treatment plans. And so it's a very rigorous program. And so we took that on in about 2018. We had to be compliant for a full year before we could apply for accreditation. And we were one of the first 20 sites accredited in the country. And we were accredited in October of 2019 and actually remain the only accredited program in the state of Louisiana. So we're very proud of all the hard work we've done with this. Our group has grown. We've learned a lot. We've definitely improved some of the quality of our services we can provide. We do an excellent job at staging with rectal MRIs and have brought in a few experts to help us learn along the way. So, we think we are providing some of the best colorectal cancer care in the country here at Our Lady of the Lake.
That's amazing. And it's so wonderful to hear that is right here in Baton Rouge. We're one of the top places to go. I can imagine you're very busy and that a day in your life probably isn't any one typical day, but can you tell us a little bit just from start to finish, what does your day look like on average?
Well, I'm a very high energy person, a little bit of an energizer bunny, I guess. I'm always on the run. So it kind of depends on the day, but usually start off my morning early. If I can drag myself out of bed, maybe exercise. If not, get to wake my kids up, my family, get to say hi to everyone. And I'm usually out the door by 6:30, usually straight to surgery. And depending on the day of the week, I might operate all day. Mondays, I usually do a lot of my big cases, like my colorectal cancers. But then other days of the week, I do a lot of outpatient surgery. And I see patients in the office about 3.5 days a week. So, 6:30 to 5:30, you can find me here at the hospital. And then afterwards, I'm off chasing my kids around to all their athletic endeavors, trying to cook dinner with the family, get homework done, try to find a little free time when I can to go out with friends, go out with my husband, play tennis. So I'm usually on the run though. I don't sit still very often.
Yeah. Well, that's good that you have a lot of energy then, since you have a lot going on. Is there a certain part of your day that you're always like, this is my favorite part of my day?
I have everything. I love my job. I love my family. I love getting to, get everything done. I think a good day for me is when everything goes as planned and efficient because I usually do have it stacked. But definitely getting home with my family and getting to regroup for the day would be my favorite time. Trying to pry some funny stories out of my kids or see how their day went and see how I have a very great, wonderful, supportive husband.
Yeah, that's great.
Dr. Talukder, you've conducted a lot of research on colorectal surgery in your career, and you joined Our Lady of the Lake back in September of 2022. Is that correct?
Yes, that's correct.
Okay. Well, great. So can you tell us a little bit about what drew you to this field of medicine and what you do today as a colorectal surgeon?
Sure. So with surgery, I just liked the procedural nature of what we do. I think that when you're a surgeon, you understand the body as a physical thing with physical properties. It feels like something. It has weight. It has mass. In a way that I think that other doctors don't. I think it's easy when this sounds really bad, but when you're handing out pills and treating patients with medicine and you're worried about these molecules, I think that you start to think of patients on a molecular level about these signaling pathways, and then suddenly everything's really abstract. But for me as a surgeon, these patients, they are physical beings. There are physical things that I need to think about. And that puzzle with those properties, that's what really appealed to me. Now, as far as becoming a colorectal surgeon, I think that's probably the number one most asked question that I get is, why on earth did you want to be a colorectal surgeon? It's kind of like getting a dentist, but you don't deal with any teeth. But for me, it's doing colorectal was really about, one, I was really passionate about being a healthcare practitioner that treated cancer. But with colorectal cancer, it's a pretty common cancer and our outcomes are really good. And even when the cancer has spread, there are surgical options for our patients. So I didn't want to do cancer surgery that didn't have good outcomes, because putting a cancer patient through surgery is very stressful physiologically. It puts not just the patient through something, but the family through something. But with colon cancer surgery, our outcomes are really good. We can get you negative margins. If you have metastasis, we can get those out. There are a lot of options. We have a lot of tools in our toolkit. And so, there are definitely other kinds of surgery out there that are sexier. But ultimately, I think that when you're making a decision, at least when I was making a decision about what specialty to pick, I had to figure out, who was I doing this for? Was I doing this for myself to be doing some cool surgery? And don't get me wrong, what I do is super cool. Or was I doing this to deliver really good outcomes for people? And ultimately, that's where I landed. And, I like the technical side of what I do is really exciting. We use every tool in the toolkit. So, we do conventional open surgery, we do endoscopic surgery, we do laparoscopic surgery. Now we do the most cutting edge endoluminal surgery. That's everything. That's what drew me to this.
Yeah. Well, that's great that you have such a patient focused way that you practice, a human way to practice medicine. And we're glad that you practice it here at the Lake.
Oh, and me too. I like, this place has been phenomenal. And when I was looking for a job, you have to understand, the healthcare system was just recovering from COVID.
Yeah.
And so when I moved to Kentucky to start my fellowship, the healthcare system was just getting back on its feet. And so I was looking for a job in post-COVID environment where I could still do, major surgery, cutting edge surgery, and see a lot of patients. And of course, because we're such a rectal cancer center of excellence with, 4 partners, the patients were here and the volume was here right away.
Yeah. You talked a little bit about, what I'm sure you're busy and just what you do every day. But can you walk us through what an average day looks like for you? Or is there a typical day?
Yeah. Luckily, so my weeks are very regimented, which works for me because like left to my own devices, I don't know where I'll end up at the end of the day. So an average day for me is usually split somewhere between doing something interventional and seeing patients in the office. So I'll spend half the day, a couple of days a week, doing ambulatory surgery procedures or colonoscopy, and then seeing patients in the office, just like today. 1 or 2 days a week, I'll do major abdominal operations. So usually for me, that's 1 whole day a week and 1 half day somewhere that I try to fit one in. And sometimes I'll try to even squeeze another one in, depending on what else is going on with me. My day starts around 5:30. I wake up and look at my phone like everybody else.
Yeah.
Okay. I know you're all doing it as soon as you wake up. And so I look at my schedule, look at my messages, and I'm trying to check my inbox to see what patients are messaging me about. And then I kind of hit the ground running, actually on my phone, doing something, messaging somebody while I'm putting away dishes and feeding my dogs and picking up after everybody. And then out of my house and here doing stuff. And I try to get home, between 6:30 and 7, just in time for dinner. And then my wife and I, we have a toddler. He's 3. So basically, as soon as I hit the doors, I'm dad. No one cares that I'm a doctor. No one cares that I'm a surgeon. No, I can tell you, no one is impressed. And my wife is also a physician, so she's like extra not impressed.
Yeah.
And so, usually we're getting supper on the table and cleaning everything up and trying to just survive till the next chaotic moment with a toddler.
Yeah.
My life is like outside of the 4 walls of this hospital is like pretty boring. I like to keep it that way.
That's great.
Dr. Finan, was wondering if you could kind of share with us a little bit about colorectal cancer itself and its signs and symptoms.
Absolutely. So like you said, colorectal cancer, if we go by gender, it's the 3rd most common because we have lung, breast, or lung and prostate and respective genders. But if we put everyone together, it's even the 2nd most common behind lung. And so no one's immune to it. A lot of people tell me, oh, I don't have a family history. Well, really only about 10 to 15% of people will. It is so common, roughly 1 in 20 people are going to get colorectal cancer. And so you will know someone who gets this. It's a cancer that grows from abnormal growth of cells lining the colon wall. So it's growing from the inside of the colon. And there's some vague signs and symptoms, but a lot of people will write them off and they don't usually come on abruptly, it can be slow change. So, anything that's going on out of the ordinary, this is not just for colorectal cancer, but if you're expecting some things like this shouldn't be happening in my body, oh, this is new, you should get it investigated. So for colorectal cancer, some of the big red flags for us are a change in bowel function, meaning, more constipation or maybe more diarrhea and frequency, or a change in the caliber of your stools if your stools start to get real narrow. Obviously, rectal bleeding is a concern for us, or black tarry stools, abdominal pain, unexplained weight loss. So all these things can be signs and symptoms of colorectal cancer. And so if you're experiencing these, you should definitely get it checked out. And the good news is colon cancers grow so slowly. So, it's not something like if you had a colonoscopy 6 months ago, the likelihood of you having a cancer is very low. Something could have been missed, but most likely it's not a cancer. The standard age for screening was always 50, but unfortunately, we've been seeing a lot higher rates of new cancers in patients 40 to 50 years old. So, about 5 years ago, we lowered the age of screening to 45. And so now everyone 45 and older should get screened. But if you're experiencing signs and symptoms, if you have a family history of colorectal cancer or polyps, you should actually start 10 years younger than a 1st-degree family member. So, if dad had polyps at 50, you should really start at 40.
Right.
And there's some other conditions like inflammatory bowel disease where we might, lower your screening age for those things. But golden rule, if you're 45, you better get screened. And the neat thing about screening that I feel like everyone's like, oh, I don't want to get that done. Oh, I don't want to do the prep. But I know it's not, no one asked me for a refill on a bowel prep or, asked to go do it again. But if you get screened, you can actually prevent colon cancer. So it's so sad to me. I think there's a lot of cancers that, maybe healthier lifestyles or healthier decisions in our past could have changed that. But with colon cancer, they start from a polyp. So when we screen someone, we are screening for a cancer, but we're really also screening for polyps. Because if we can remove the polyp, we actually stop the process of it growing into a cancer, and we can prevent colon cancer. So, if there's one screening I think you want to get done, like go get your colonoscopy. It really could save your life. And if you think a colonoscopy is bad, you really don't want colon cancer because then you're talking
Yeah.
surgery, maybe chemo, maybe radiation. And so, take all those preventative steps, especially if you don't want to end up with colon cancer.
Wow, that's great to hear that it is one of those cancers that is preventable if you stay on top of your screenings and stay in tune with your body and get things checked out if you need to. But for those who the treatment for those types of conditions and the surgical procedures that you perform, can you talk a little bit about that for people who do end up developing into cancer?
Absolutely. So, typically when someone's diagnosed with a colon cancer, they'll be sent to our office. And we usually, obviously start with a clinical history, try to find out, what signs or symptoms they've had. Also, we always, dive into family history. Is there any genetic causes that we should be concerned with? Because we can do some special testing, and sometimes that will actually change our treatment plan. And then most importantly, we'll order some more testing. So we order some x-rays, usually a CT scan of the chest, abdomen, and pelvis. And if you have a rectal cancer, we usually get an MRI of the rectum. And those will help us assess what stage your cancer is.
Yeah, definitely. And it sounds like a long process for those patients. And what's the recovery like for those who go through, the chemo and the surgery and potentially chemo again? What's that recovery look like for them?
Best case scenario is someone maybe has a early colorectal cancer. And so again, the importance of screening, because even, we'd like to prevent all cancers, but if we can find them at early stages, they're much more curable. So if someone has a surgery, typically in the hospital, 2 to 3 days, we can do most surgeries minimally invasive, either laparoscopic or robotic. And then overall recovery can be on average 6 weeks. I would say 4 to 8 weeks, kind of depending on your health status going into it. If you have any complications recovering from surgery. But I typically tell patients to anticipate 6 weeks off to recover, because your body still is going to use a lot of energy to heal.
Yeah.
And you've got to give your body that ability to heal itself so you come back with the same energy. And if you get chemotherapy, often it's about 4 to 6 months of chemotherapy after surgery for colon cancers. And then again, rectal cancers can be different. But if you have to go the whole regimen of doing chemoradiation and then more chemotherapy and then surgery, and sometimes even a secondary surgery, if you have to have a temporary ostomy, the whole process can actually take a year. And It's interesting you asked me that, because I'm a big drawer. I like to draw pictures for everyone and try to draw them some diagrams. But, even when I have a patient with rectal cancer, I usually even try to draw a timeline, because I want them to be able to base and, work around, know when they'll have breaks, maybe a vacation or something, but also to just put their head around. This is probably going to take us a year to really treat.
Yeah. Well, that's great that you do that. I'm sure they appreciate it, because it's so confusing already as is. And then you give someone a diagnosis that I'm sure they, just tune out after, because it's just overwhelming. So it's great to hear that you do that for your patients.
Aren't necessarily just for checking for colorectal cancer. They can also kind of screen for some other conditions like inflammatory bowel disease. So can you tell us a little bit about the other ways that you can use a colonoscopy maybe to learn more about what the patient is dealing with?
Oh, yeah, sure. So, predominantly we use colonoscopy as a kind of a diagnostic tool when patients have some sort of change in their bowel habit, bowel function. So a lot of times we use colonoscopy as a tool when patients have sort of some kind of chronic change in their bowel habits. Colon cancer is kind of always at the top of our list, but there are other reasons that can happen. So the other reason might be something like an inflammatory bowel disease. Sometimes there are functional issues with the colon that we need to look at to make sure that that's actually what's going on versus some anatomical problem. So, there's a lot of uses for colonoscopy for us, far and above colon cancer, although it's certainly that is the best and most used tool for us.
And I think one of the neat things with colonoscopy, sometimes patients will ask, like, for screening purposes, like, should I do the stool DNA or the Cologuard test? So you can, but if you get a positive, you still get to go do a colonoscopy. And the beauty with colonoscopy, and if there is a different condition going on, is we get a good visual inspection of the colon. So if I see a cancer, 95% of the time, I know it's a cancer, but it's also therapeutic. So I can do biopsies that can help us make a diagnosis. A lot of times we can remove polyps or, do therapeutic interventions. So It's not like just going and getting an x-ray and it's stagnant and then you have to go to the doctor and say, what are you going to do? We can actually look through the whole colon, get a good visual inspection, tell you our thoughts, but we can also intervene a lot of times and get further biopsies. And, maybe even if it's a huge polyp or something, we can get it out and avoid you having to have surgery.
Mm-hmm.
Yeah. Well, I guess our next question really is about the importance of how you talk to your patients about colonoscopy. And it's probably one of the screening types that have the most stigma around it because people are scared of it and it has before night process. And so are there any myths or concerns that you want to dispel about having a screening?
I think that one of the things that patients often ask me is this going to be painful? No, it's not going to be painful. And it's hard to wrap your head around because of the scope. And when I try to tell them is, you've probably had bigger bowel movements than the scope. So, and then the other thing that people are concerned about is sedation. And are they going to be comfortable? Are they going to remember? Are they going to feel anything? That's very important to us. I mean, we don't even start until we know that the patient's adequately sedated. Those are priorities for us. If the patient's comfortable, we're going to be able to do a better exam. And the exam is actually more comfortable for us to do when the patient's not in pain. You can't believe the number of times where I've finished a colonoscopy, I'm going to talk to the patient in recovery, and they thought they dozed off and hadn't even started yet. So it's like kind of one of those things where you fall asleep on a plane on the tarmac and you wake up and you didn't even take off yet.
Yeah.
So they think that, but they wake up at their destination.
Yeah.
So those things are very important to us, is to set expectations, kind of confront their fears. And you're right. And then kind of discuss the stigma around getting a colonoscopy.
I think the probably biggest fear is doing the prep. And I mean, it's a necessary evil. I always tell my patients, if your colon's full of stool, I can't see anything either. So there's really no benefit in doing it. So, a prep's not fun for anyone. There's different ones out there. There's lots of low volume preps out there now where you might just drink a 16-ounce glass of medicine and then a liter of water and repeat that. There's some pill preps out there now. So, a lot of times I'll ask patients, like, pick your poison. Like, if you get nauseated taking pills, probably don't want to do the pill prep, do the liquid prep or vice versa. So we'll work with patients on that. And again, I think I said this earlier, but no one ever really asks for a refill in their bowel prep. It's not like a great cocktail. They don't want to serve it Friday night. But again, you have to get it done. And that's probably the hardest part of the whole prep. But, if it's the worst thing you've really ever had to do, like, thank God you're so healthy. Because this is the easiest thing any of our cancer patients have gone through. So, you have to do it. And the other lucky thing is if it is normal, you only do this once every 10 years because colon cancers are so slow growing that it really takes about 10 years from a polyp to form into a cancer. And so for the majority of people getting a colonoscopy, it is for a screening test. Now, if you have polyps or a family history, we might bring you back 3 years, 5 years. It depends on the number and size. But, if you are clean, everything's normal, you get the golden ticket. I always tell everyone you get 10 years. And so, I think the prep's not fun, but to do it once a decade for colorectal cancer screening, it's not the end of the world. It should not prohibit anyone from going and getting a screening.
And you can pretty much just go back home or back to work after you're done with the screening, right?
They give you sedation. So I think most anesthesiologists will, you can't drive home by any means.
Right.
But for the most part, until you take the day easy and don't drive, but there's really no long lingering effects.
Right. I tell my patients, by the next day, you can do whatever you want. So if your spouse has got chores for you to do, guess what? You're doing it. So that day, definitely no alcohol, no heavy machinery, no making big life decisions. So I tell my patients, don't drink beer on a bulldozer and you're going to be just fine.
Yeah. Just avoid that.
Yeah.
Well, thinking about that one-on-one interaction with your patient, obviously we know it's a personal conversation. It's something that they might be uncomfortable talking about. How does listening work for you in that one-on-one interaction? Like, how are you making sure that your patients feel like they're in a safe space to share with you and tell them their concerns?
I think I always just start with a history. I guess I feel like I'm a little Sherlock Holmes. Like, I like them to tell me. Sometimes people show up with a pathology report and a colonoscopy. It says, oh, I have cancer. But a lot of my patients have other, rectal issues. They might have a lot of pelvic floor issues. And so I always just listen to their story. Tell me what's going on. And by asking a lot of key questions, a lot of times I can be 95% sure of the diagnosis before I examine them. So I want to confirm it. And I'm not always right. So I'm like, let's take a look. This is what I think is going on. But I also usually try to ask my patients, what are your fears or concerns? Because some people will walk in And, they had a little bleeding and they just said like my 38-year-old coworker just died of colon cancer and I'm afraid I'm going to die of colon cancer. And so that's important for me to know up front when I go to examine them. Say, look, I see a big bleeding hemorrhoid here. That's really what I think is going on. If it doesn't resolve, maybe we need to do more workup or, lots of examples like that. But I think knowing why people are there, and when we ask the whole history to try to figure out what's going on, but also trying to figure out, what brought them. Are there any concerns they have? Sometimes when people tell me they've had things going on for a long time or, maybe they're 60 and never had a colonoscopy and they just wanted to meet, I always ask, well, why? Like, are you scared to have this? And sometimes it's like, oh no, I've just been taking care of my, family members and my mom had a stroke and then a heart attack and I just put them off my health. But other times it's, well, I know someone who had a bad complication and I've just been scared to do it and vice versa. So I think, like you said, listening and really trying to find out, patients will often tell you what is wrong with them if you just listen to their history before you examine them, but then also trying to find out, what their expectations are, what brought them in, do they have any fears or, issues they want to resolve. I think that helps a lot.
Yeah. I think people in general are just really uncomfortable with silence.
Yeah.
So they will just fill it. And so I'll just kind of sit there and I kind of wait to draw it out of them. And a lot of times they'll have these issues for years and you kind of have to figure out, well, what's different about now? Why now?
Mm.
Or like if their symptoms just started, sometimes they can't quite put together this issue because it's so stressful with what's been going on in their life. So if someone, we talk about hemorrhoids all the time, but if someone came in with hemorrhoids, they might not have connected, well, this started after they went on a cruise and they were super constipated or they had a bad bout of diarrhea or something like that. So sometimes you have to, as a physician, piece together these disparate pieces of information that the patient's just not doing it for them because they're just so distracted and anxious.
Yeah. I know we talked a little bit about what sets Our Lady of the Lake apart and in our colorectal services that we offer. Can you talk a little bit about the services with Our Lady of the Lake Cancer Institute and if there are certain accreditations or accolades that set us apart in the region as far as cancer treatments with colorectal conditions?
So I'm proud of what we've done in the space of colorectal cancer. We have built a longstanding multidisciplinary team. It was actually started by my partner, Lewis Barfield, I think 2-3 years before I came here. So I think it was around 2007 that started. So we've really just worked well as a team. I think we've formed a lot of camaraderie and it's really pushed us. So, as new things come out, we can also evaluate, we weren't doing the best job at staging with rectal MRI. So we got funding to have a world-renowned expert come teach us. In the space of rectal cancer, a lot of patients are now doing what we call total neoadjuvant therapy, where they get all chemoradiation up front. And there's actually a percentage of patients who will have a complete response and be able to avoid surgery. So we've really adopted that philosophy. We've started ordering a lot of circulating tumor DNA, which is another adjunct to evaluate residual cancer in patients, where it takes a sample from their bloodstream and compares it to their original tumor. There's just a lot of cool, new, groundbreaking things. There's new immunotherapy out there. There's new, chemotherapy regimens. And so we're just trying to really stay on the forefront of it. We do have a good research institute as well. So we're able to offer research opportunities to patients. Some of them are observational. Some of them are new drug trials. So I think we really just have a great package and a lot of good camaraderie among the providers, because I can't provide alone just good colorectal cancer care. Like I have to have good radiologists to help me know, where the tumor is spread. I have to have good pathologists that give a very good expert report. I have to have good medical oncologists to give chemo. So I'm proud of the group we have. And I think we've really worked hard to collaborate. And, it also allows us to just really talk openly about patients. I think that camaraderie and that collaboration on all of our patients really helps us provide excellent care.
Great.
But it's more than just medical. We also have nurse navigation as part of that suite of services. And so when you're talking about being treated for rectal cancer, for example, we're talking about seeing us, the surgeons, a medical oncologist, a radiation oncologist. That's a lot of appointments. That's a lot of need for transportation. For some of our patients, that is very difficult to coordinate and very resource intensive. Some people just don't have those, drivers and people to get them in and out of appointments. So that's something that our nurse navigation service can do for our patients. I think that really sets us apart from centers that just don't offer the full suite. We think about the full patient.
Yeah.
And so it's not just conversations about their disease or their pathology that we're having. We're having conversations during our tumor board about, well, can this person get to their appointments? Is there a language barrier? Do they have a cell phone? I mean, those are all things that we consider as we consider the total treatment of this patient.
Yeah, that's important to consider, especially, just how they're getting there and to really understand what are other things that could be stressing them out or just and how we care for them.
I'd love to hear if you guys have any sort of patient stories or experiences where a patient ended up finding better health or better outcomes through screening or through treatment here. It kind of puts you on the spot.
There's so many. I think some of the greatest wins for us are patients who maybe can avoid surgery. And so, again, with us doing some more total neoadjuvant therapy with patients starting with radiation and then doing chemotherapy, we have a number of patients that will literally have their tumors disappear. I mean, I was supposed to do a case today, actually, and the patient got repeat staging. We didn't see the cancer had spread anywhere. We repeated an MRI. And the rectal cancer had really gone away. It was just a scar left. So I brought her in last week and I did another scope here in the office. And literally, there was no tumor left. It had just melted away and there's a little white scar. And those patients, it's very rewarding because if there's no evidence of residual cancer and they've had a good response and they want to go down a non-operative route, we call it organ preservation, they have that option if the cancer completely responds to the preoperative therapy. Now, the other therapies are without any other consequence for sure, but if we can remove or avoid removing someone's entire rectum, they're going to have much better bowel function. And with this, it's going to be a very intensive follow-up, though. I'm going to see her every 3 months for 2 years and every 6 months, and it's going to be a lot of scopes and blood tests and x-rays, but only about 30% of people will fail that we put in that paradigm. So if people have a good response, and again, here I'm a surgeon. So, I always laugh because, I only get paid to operate. That's what I like to do. I'll joke with people. So if I'm offering them a non-operative route, I'm like, whether it's again, hemorrhoids or colon cancer, I think that they need to understand, this is really what I think is best for your quality of life. And here's, a road we can go down. So I was super excited for my patient today. She didn't have to have a major surgery today. I mean, it's a big win. And you just become really invested with your patients. So you become close with them. I mean, there are some conditions we'll see someone once and never again, but our cancer patients, we see a lot for about 5 years, helping survey them after their surgeries and helping with any functional outcome issues. So we can get lots of wins. And sometimes we just get wins and benign stuff. If someone's having horrible hemorrhoids and they're having a flare every week and they're sitting in a bathtub and skipping their kids' games and avoiding vacations, and you can just do a hemorrhoid surgery. Found out fine. 3 weeks later, they have a really big quality of life. So a lot of it comes down to me. We want to try to avoid people, having some mortality from like a cancer or colorectal. But for a lot of the conditions we treat, it goes down to quality of life. And so if we can improve someone's quality of life with surgery, again, that's a huge win.
Yeah, definitely.
I think that really dovetails nicely into kind of what we do from a multidisciplinary standpoint. Watch and wait. When I started my fellowship training, I think I would tell my patients maybe somewhere between 1 and 4 and 1 and 3 patients was going to have a complete response. But that number keeps growing. The number is getting better. And I think because we trust our oncologists, because we trust our radiologists now, I think we're much more comfortable with a watch and wait strategy or non-operative strategy and letting the preoperative treatment work. And, even if the cancer recurs, it could be 5 years later. We know that there's, over a 95% salvage rate, meaning that if those patients have a recurrence, we're able to get that out. And that means, more years of high quality life.
Yeah.
Living with, this disease. Now, some people can't handle that, but if we're confident in our system and we're confident in our data, then that's something that we really can push to our patients.
Yeah, that's great. It sounds like there's a lot of innovations that are being developed. Is there one thing that you're most excited about or inspired by for the future of colorectal conditions?
Again, we're just plumbers. I'm not sure that there's a huge innovation, but I think some of the, just the multimodality ways we can treat people. So, I think getting more to non-operative modes, less invasive. We've come up with tons of great new like pain regimens, and we try to avoid a lot of narcotics. And I think we just try to make the overall experience better. I mean, one of the things I think most affects a patient's outcome is having them prepared for surgery as well. And maybe this just comes with time and, having to answer a lot of questions on post-operative phone calls. But I mean, we do a lot with education, whether it's anorectal surgery or a big abdominal surgery. So we give everyone a little book. We go over it with them. We kind of tell them what to do before surgery, what surgery is going to look like, what the recovery is going to look like, how long they think they need to be off work. Sometimes patients will come in and see me for hemorrhoids and they think it's just like getting a haircut, like in and out, we're done. And I'm like, well, it's about 3 weeks to recover and you need a little hemorrhoid holiday and they don't want to use their vacation time off. So, I joke, well, I'm not going anywhere. Come back when you're ready. And, so I think helping prepare the patients is really beneficial.
For sure.
Well, I'd imagine too, with the advancements in minimally invasive surgeries, especially for your older patients, because you were saying 70 and above, there's a high likelihood that they might have some of these conditions. It probably benefits their quality of life to be able to have some of these options and alternatives available.
Oh, absolutely. So, I mean, if we can, get people up and walking, the day after surgery. Even if you look 20 years ago when I was training, we'd put people on IV pain pumps and they'd have tubes in their nose and we'd have them laid up for days.
Mm-hmm.
We get people out of bed that night. We feed them immediately after surgery. We start them on oral pain pills, including just simple things like Tylenol, because those work. And we don't need to always go to heavy narcotics in patients. So, I have no problem operating on 80-year-olds. I actually think if you're 80 and you made it to surgery, you're probably tough as nails. But, we operate on a lot of octogenarians and they do well. But I think just having learned and knowing. So I think some of the more advances are being able to do more and more minimally invasive surgery, probably having more advanced diagnostic tools and more adjuncts. And I think with anything in medicine, everything's just become so specialized that it's hard to be an expert in really complicated disease states if you're only doing it once a year. So, I think maybe we take for granted, but this is all we do. Like, I don't do any other type of surgery, just colon down. But it also gives us, a lot of expertise. And while I do a lot of pelvic floor work, for example, so people might come to me, they have a lot of pelvic floor pain, or they have had a lot of pelvic floor muscle tears after childbirth, or maybe they literally don't know how to use their muscles to go to the bathroom correctly. All that awareness can actually help me though when I have a rectal cancer patient post-op that's having pelvic floor problems, because again, it's the same pelvic floor. So some people are going to have triggers from pain, from radiation, from other things. But I just think our combined knowledge and just, it might be, we might use that knowledge for different disease states, but we all need to understand how the pelvic floor works. And truly and honestly, there's not a lot of other doctors who really are concerned about how the muscles down there work. Yeah. It's our bread and butter. So, I think that the wealth of knowledge, just because that's all we focus on, is helpful.
So I tell our trainees that are interested in doing colorectal surgery, man, you signed up for a hard path, because we've got to know how to do endoscopy. We need to know how to do conventional open surgery, laparoscopy, now robotics, but more is coming. And I think, so now a lot of us are doing endoluminal surgery. Kelly and I both do TAMIS. It's just a matter of time until we're doing robotic or TAMIS or transanal minimally invasive surgery. So endoluminal surgery, taking tumors out without making an incision on the abdomen. All of this technology is becoming more miniaturized. So I think endoluminal surgery is probably what's coming up next. And the efficacy of that is what we're going to have to figure out. But technologically, I think it's already here.
Yeah.
And so I think our job kind of at the vanguard of that is to figure out what is most beneficial for our patients and really prioritizing good oncologic outcomes more than anything else. So we have to accept technology, but not be washed away by it, and really protect oncologic outcomes. So for me, I think that the possibility of doing endoluminal surgery for rectal tumors is very exciting. I think that's what's coming next as the robotic instrumentation gets smaller. And, like I said, the challenge of all this technological development is that it's outpacing our regulatory processes. So the technology is changing so fast that FDA and all these other regulators just can't keep up. So I think it's our job as physicians to sit back and say, well, okay, is this safe? Does this make sense? And then from a minimally invasive standpoint, when we're talking about octogenarians, I think it used to be kind of old thinking that if someone was old and frail, they couldn't benefit from minimally invasive surgery. Oh, we shouldn't put them on the table and do a longer operation. Well, what we've actually found is they'll do better if you keep them on the table and you give them minimally invasive surgery because the physiologic hit is so much less. They're walking sooner, they're moving, their pain is less, and they benefit more from that. And so I think both of us in our practice, and I think all our partners are much more open to giving our older, more frail patients, the same cutting edge surgery that we wouldn't hesitate to give a 30-year-old.
Well, would like to kind of ask some more personal questions, just your perspective on things. First off, being what inspires you daily in your work?
Oh man, that's a tough question. I mean, for me, I think the patients are really inspirational. This can be a really, really hard job. It can be demoralizing at times. And sometimes no matter how we work, patients just aren't satisfied with us. And sometimes it has nothing to do with us, but it has to do with their disease. But there are patients who just have all of these challenges, but bounce back from a difficult surgery, from a surgery with complications, have a great attitude and drive themselves to good outcomes. And to me, you never know who that's going to be. And that's kind of what keeps me really motivated, is because I don't really know. I might have a hunch about how someone's going to do or how they'll respond, but I don't know till they're put in that situation. And you know what? They don't know either.
Yeah.
Mm-hmm.
I'd say I'm inspired a lot by patients, and I do really just love what I do. And I love being able to fix a problem or help someone through a difficult situation. I mean, I think that's what drove me to become a surgeon. I like the hands-on. I like the challenge. I mean, I might have done, thousands of this surgery, but every day could be a little bit different. And I do truly love the relationships with my patients. I mean, no matter how big or small the surgery, it's exciting when you help someone, when you can improve their quality of life, when you can maybe save their life from cancers. It's very meaningful and gratifying. And I don't think that a lot of professions get that. My husband's an attorney and he's like often jealous. Like, I get a thank you card or a hug or we're out and your wife saved my life. And like, and I don't need that. Like, but it's just so gratifying because he loves his job and I don't want to say anything like that, but it is extremely gratifying when we can positively impact so many lives. And I usually actually ask all my patients, are you glad you had the surgery? Because I'm actually still surprised sometimes. I mean, hemorrhoid surgery is not fun to get over, a lot of, rectal surgery. And so I've always asked that question because I was always like, someone's going to tell me no. Some people might say, I'm going to wait till my next visit to answer you. But I ask all my patients. And so I usually always want to know, like, are you satisfied with your outcome? Yeah. Did we achieve what you wanted? And that's just really rewarding. So, I mean, I think that is what keeps bringing me back and drives me every day because it's not just, punching the clock. Like, I do really feel like I'm making a difference for my patients, and it's rewarding to do that. And it's rewarding to learn from them because, they'll teach me too. You know what helped my recovery? I should have done this. I should have done that. So, I learn a lot from them as well.
Yeah, that's great to hear. This is a more fun question, or it can be fun or professional. What are you listening to these days?
My 9 and 12-year-olds playlist. So you probably really don't want to know.
That's fun.
Yeah, they are now making their own Spotify playlist and sharing with me, and it's making me look really old.
Oh no!
We're having to learn about all these new artists, right?
Yes. I'm like, who is this?
Well, now you'll be on the trend, in the know.
That's right.
Yeah.
That's right.
Like, I'm at that age now where I don't even know. Like, I've lost contact with what is cool. So it's just beyond my reach. So, like, me and a group of friends from college, we all share music with each other on this group chat. And like 90% of that music is from Peloton playlists, which is just like says a lot about, like our ability to access cool stuff. So when I can listen to music, I'm listening to stuff that they share with me. But like most of the time I'm listening to my wife summarize like what she heard on some murder podcast that she's listening to. So I get a lot of like secondhand fear from her. But yeah, that's those two things.
Thanks for sharing.
Yeah.
It's fun.
What's one thing, I guess, that you suggest to all of your patients just to better themselves?
Take fiber.
That hurts.
If you want to know if there's one thing, and this probably wasn't the most appropriate answer, but I do think that half of the anorectal conditions we treat are due to poor bowel function, and it is not a rite of passage to live your life constipated. And so merely drinking 80 to 100 ounces of water and taking 25 grams of fiber a day in diet and supplements is the best advice a colorectal surgeon can give any human being. It will keep you out of the office. An apple a day will actually keep me away. There's 3.5 grams of fiber in an apple. And you should know how much water and fiber you eat and drink every day. And it will actually prevent a lot of the colorectal issues that we treat. So it's kind of funny. It's hard to get out of my office without getting a fiber packet. I'm like, do you get the fiber? Are you taking your fiber? How much water are you drinking? How much fiber are you drinking? And then I drink lots and lots of water all day because all I do is talk to people about drinking water. And even if they've had surgery, the best thing to keep their bowels regular, water and fiber.
Wow.
So that's my religion.
What
yeah,
else?
I preach fiber. Yeah.
What else outside of apples? I'm trying to think of.
Avocado, spinach, blueberries. I mean,
Look, there you got a smoothie.
There you
Just
go.
put
Right.
it in a smoothie.
that's what I drink every morning.
Yeah.
A green smoothie.
I mean, every patient's just so different, but, for anybody, I would say, listen to your body. No one knows your body better than you do. And you have got to be your best advocate for what you need. No one's going to figure this out for you better than you. And so you can come to my office, but if I'm missing something, I need you to pull my ear and get me to figure this out. And if you're persistent for yourself, for someone you love, that's just going to get you the highest level of care, the highest quality of care. Be your own best advocate.
That's great advice.
And I think on a more serious note too, you should still take your fiber. But, I do think that I'm just a real big healthcare advocate. I'll try to teach my patients how to eat, how to read calories when they go someplace, quit smoking, quit drinking, exercise. I mean, I think just being an advocate for overall health, and it's amazing. I'm so proud of the number of people I've gotten to quit smoking or to lose weight or to start exercising. And sometimes, though, people will have a huge life transformation when they have a major diagnosis, like it's a cancer, diverticulitis, or something. Even, again, rectal surgery, patients will eat really healthy when they're worried about what's coming out after they've had surgery down there. So it's just amazing, though. A wellness coach had actually taught me this that the organization worked with a lot of physician well-being, but we were trying to actually start developing some programs for patients because when they have a major life event, it's usually a good checkpoint. Yeah, I got to start living healthy. Or, oh my gosh, I've eaten really well. I didn't eat any fast food or candy and I've lost 10 pounds after my hemorrhoid surgery. I feel great. I'm going to keep this up. So I'm let's keep doing this and I'll check in at their next visit. But I think it is a really good point in time to help advocate for people to really make some good life-changing decisions for them, for their family. And that can really just lead them on a better wellness journey. I would just say, if you have any concerns, any signs or symptoms, I mean, nothing's too small. If you need to come talk with us, we're here for, major life events like colorectal cancers and stuff. But we do treat a lot of benign stuff. I mean, probably 75% of my practice is dealing with fissures, fistulas, rectal prolapse, hemorrhoids, pelvic floor disorders, perineal disease. So, we do a lot of benign conditions. Some people say, oh, I didn't want to bother you with that. But, if you have a question, a concern, if it's negatively affecting your quality of life, just come ask us. We're happy to see anyone. And we understand that it's uncomfortable, but we're used to dealing with this and we can make you feel comfortable and at ease and hopefully give you the answers you need.
Yeah, just to dovetail off of that, that thing that you've been freaking out about, it's probably not cancer. Okay. But, and you're probably not alone. I mean, this stuff, you're just not going to be talking about this with your friends. You're not going to supper club or tennis and talking about this with your buddies, but you're probably not the only person that's got it.
Mm-hmm.
And again, it's probably not cancer, but come see us so that we can be sure. I think that, when you don't know, that's kind of where the boogeyman lives. And so your mind will just take you to the most anxious place. And back there, it's a hard place for you to check yourself. So that's why we're here.
Yeah.
It's good stuff. So thank you so much for both of you for joining us today. This was great.
Thank you for having us.
Absolutely. Thank you for having us.
And listeners, thanks for tuning in. We'll have everything our doctors mentioned and other helpful resources linked in the show notes. We'll be back soon with more episodes of Doctor Will Hear You Now, a podcast from Franciscan Missionaries of Our Lady Health System.
And if you have ideas for topics you'd like to hear on the show, email us at podcast@fmolhs.org. Thanks for listening.